This program is funded in part by grants from the Foundation for a Healthy Kentucky and the Kentucky Medical Association through a grant from the Anthem Foundation.
Until recently, the news about lung cancer was uniformly bleak, but the tide is changing. In this program, we examine how early detection through low-dose CT scans and new treatment modalities are increasing survival rates. And we learn more about the 20% of lung cancer patients who never smoked, who are desperate for others to understand that we are all at risk for lung cancer.
My hashtag is anyone with lungs.
This program is part of our series Fighting to Breathe, where we examine the undertold story of lung disease in Kentucky, including lung cancer, COPD, and asthma. Explore the latest advancements in treatments, and meet healthcare providers and advocates across the state who are working tirelessly to help us all breathe easier. Welcome to another installment of Fighting to Breathe, KET's three-part series on the undertold story of lung disease in Kentucky. I'm Renee Shaw. In this episode, we focus on lung cancer and new advances in both treatment and early diagnosis. We began with my interview with Dr. Timothy Mullett, a professor of thoracic surgery at the University of Kentucky and a leading proponent of low-dose CT scans for early detection of lung cancer. When it comes to lung cancer in this state, we are up against a lot, aren't we, in Kentucky? Can you paint the picture for us in the status of lung cancer in Kentucky?
So, lung cancer in Kentucky is a dominant feature in our cancer landscape. The burden that we have in our state is larger than any other state in the United States. But at the same time, I think that we're beginning to see some new opportunities and some new experiences to be able to see that burden hopefully begin to change.
So there is clearly a stigma that is surrounded and associated with lung cancer. Talk about that stigma and the negative consequences that it can have.
Lung cancer is often associated with tobacco use. It's seen in areas with lower education. It's seen in patients that may have lower income. It often carries with it some sense of nihilism, or a sense that they brought it upon themselves. And then that brings a whole bit of guilt that comes in to say, I knew I should have quit, or I knew I should have. And that's not really fair to the patients, because there's a lot of people that are smoking that don't get lung cancer. And there's a lot of people that have quit smoking, have made good decisions, and yet they've still come up with the diagnosis of lung cancer many years after they may have quit. Mm-hmm. And again, so I think that association with a disease that historically has had a very lethal diagnosis, and so there's a sense of fatalism that patients may say, I've got lung cancer, why bother?
And to that point, there was a time when lung cancer diagnosis was dire and there were limited treatment options, but times have changed and medicine has changed and there are more options now. So can you speak to that?
Most lung cancers are diagnosed in late stage. They're diagnosed after the patient's already had a cancer that formed in the lung, has grown, and has spread to someplace else. Many years ago, chest x-rays were studied and were found to be ineffective at finding lung cancers when they could make a difference. What they started to study was something called a low-dose CT scan, where it was receiving less than a third of the dose of a normal radiation exposure from a CT scan. And so it allows us to be able to get a scan of the lung, find a nodule, find a spot in the lung that is small, and if it's too small, we can repeat the scan later and see if it's getting bigger. If it's large enough, then we can then think about doing a biopsy or confirming that that's a cancer, and then get that patient in for the treatment that they need.
Currently, the U.S. Preventive Services Task Force recommends these screenings for people who are ages 50 to 80, have a tobacco exposure of at least 20 pack years, and have smoked within the last 15 years. Dr. Mullet and others at the Kentucky Leads Collaborative, which stands for Lung Cancer Education, Awareness, Detection, and Survivorship, have been working intensively to increase use of this tool in Kentucky. So what percentage of people who are eligible for screening are actually being screened?
In the country, it's about 4 or 5% of the eligible population that are being screened. And that's what we feel a sense of urgency to try and get more people into this. But it's taken some time to get this into the primary care office, to get them to do that. Those efforts have actually been very successful in Kentucky. We actually are in the 3rd or 4th highest in the country for lung cancer screening. We're at about 13% now. We're currently number 2 in tobacco exposure as a state, and so we certainly would like to see us drive down our tobacco use over time. But as I mentioned, even if everybody quit smoking now, we'd still have a risk for these patients to get into lung cancers, to develop a lung cancer, and so it's really important that we get these into lung cancer screening.
And these screening efforts, it's not just a one and done, it's a rinse and repeat, right?
It is. Again, we get a scan, and let's say there's not a nodule that's detected. There still could be a small cancer that's developing over the course of time, and so you need to get a scan every year. And that's really the only way that we've shown the real benefit for lung cancer screening is when patients come back year over year.
At St. Elizabeth Healthcare in Northern Kentucky, primary care physician Mike Gieske and thoracic surgeon Royce Calhoun have built one of the most successful lung cancer screening programs in the state, if not in the entire country. They recently reached the impressive milestone of 20,000 screenings.
I've been in primary care for 34 years now, and I've experienced a lot of frustration with lung cancer and have seen the dismal outcomes. We find it too late. If you catch it early, you can make a great deal of difference. We're finding 56% of the cancers that we find through our screening program in stage 1, where you can have, again, a greater than 90% chance of cure. We're finding about 69% of the lung cancers in our screening program in the early stages, either stage 1 or stage 2.
The St. Elizabeth Lung Cancer Screening Program is built on several core components: shared decision-making with the patients, tobacco cessation counseling, comprehensive care coordination with nurse navigators, and a multidisciplinary nodule review board that examines every nodule and makes careful recommendations for follow-up.
It was important to me that we put together sort of a programmatic approach, because one of the concerns with lung cancer screening is you're screening the chest with a CAT scan. Unlike mammography that's just looking at the breast, or a colonoscopy that's just going up in the colon, there is a lot of stuff in the chest. So you're going to find cardiac disease, you're going to find aneurysms, you're going to find innumerable things that could be like a Pandora's box. And that's been one of the concerns about screening is, hey, you're going to see a bunch of stuff, and a lot of it may just be nothing. But if everybody starts, kind of going here, there, and yonder, and biopsying stuff and everything, you can actually do a lot of harm to patients. And by the way, a lot of patients have pulmonary nodules, and the majority of pulmonary nodules are benign, like over 97%. So you really need to think about how you're going to process all that information in a methodical fashion.
Patient Glenna Courtney is one of the beneficiaries of this comprehensive approach to lung screening.
Where you can see this tiny little spot there, and that was your cancer. It was just 1/4 of an inch.
Initially, I went in for an annual exam with my family physician, and he requested that I get the low-dose CT scan as a baseline record for any future ones. And we had a follow-up in a year, and that's when they spotted something. And then we waited for 3 months to see if that little spot would grow any, and it did. So that's when we decided to do the surgery and the thoracic surgery, and they went in and did a wedge, and it was cancerous. They got it all, and I did not have to take radiation and chemotherapy due to the fact that I did the early lung screening test. I tell everybody that I know to go get the scan. It's well worth it. Your life will be protected by having it.
If you believe you qualify for a low-dose CT scan, please contact your primary care provider. In our next segment, we're going to look at advances in treatment that are helping lung cancer patients live longer. I spoke with Dr. Jill Kalesser, a pharmacist specializing in anti-cancer agents and the co-director of the Molecular Tumor Board at the University of Kentucky. There's been a dramatic change in the practice of cancer treatment, that it's not just radiation, it's not just chemotherapy anymore. Talk us through the new opportunities and options that are available.
Well, what we've learned in cancer over the last 25 years or so is that cancer is actually caused by mutations. And those mutations are usually one of two types. They're either oncogenes or tumor suppressor genes. And tumor suppressor genes are kind of like the brakes of your car. So if you can imagine, if your brakes go out, your car goes out of control. And oncogenes are more like the gas pedal. And imagine your gas pedal just being stuck down to the floor. Then again, your car goes out of control. And imagine if you had both those problems,
right.
No brakes and your pedal to the metal. And that's actually what happens in a cancer cell, is that there's a combination of mutations in brake genes and in gas genes that cause the cell to go out of control, and that's what causes the cancer. And so we've learned that over the last 25 years, and the major advance that we've made really is that we've identified drugs that work on those specific mutations in those genes. And the great thing about those drugs is that they only target the genes in the cancer cells that are mutated. So they work better and they have less adverse effects.
And they don't attack the other healthy genes.
Right.
Let's talk about people who are diagnosed with lung cancer and what they can do to find out what their next steps should be. Requesting tumor gene sequencing. So tell us what that means.
Yeah, so when somebody is diagnosed with cancer, they first have to have a biopsy to confirm what type of cell it is and what the origin is. Then the next thing that they have to do is have a scan to kind of see how far that the cancer has spread. And then we take the biopsy that is obtained or the tissue sample that's obtained from the biopsy, and we send it to the lab to go ahead and do that sequencing. And what the sequencing does is it tells us, how many mutations are in oncogenes or gas genes and how many are in tumor suppressor genes. And then once we have that report, that's what we can use to identify a therapy that might be effective for that patient.
And so there are several terms here that I'll have you define to help us understand targeted therapy. What is that and how does it work?
So the targeted therapies are drugs that are usually oral medications. And again, they only work on the brake genes and the gas genes. So they go specifically to the cancer, they go specifically to those genes.
And immunotherapy?
So immunotherapy is a little bit different, but that's also another major advance. When I was talking about the gas and the brake genes, so when you have those mutations, they make an abnormal protein. And so the job of the immune system is actually to find those abnormal proteins and get rid of those cells before they can develop into a cancer. But the cancers are actually kind of sneaky, and they have something that is it's kind of like Harry Potter's invisibility cloak, or the Romulans had that technology in Star Trek, the cloaking device. And so the cancers will kind of put this cloaking device around them and hide from the immune system. And what immunotherapy does is it comes and it just pulls off that cloaking device. And then the immune system can see the cancer, and then the immune system actually eliminates the cancer cells.
So the immune system is doing some work there.
Yeah, the immune system is doing most of the work.
This is something that many people may not know about. It's the Molecular Tumor Board. You started this in Wisconsin, and the University of Kentucky grabbed you and recruited you to start this type of program here. What is it and how does it work?
So the Molecular Tumor Board is an interprofessional group of people. So there's doctors, there's pharmacists, there's genetic counselors. And remember I was saying when we send the tumor off for sequencing, it comes back with a report. And so this report can be 50 pages long. Patients can have 15, 20, 30 different mutations with 4 or 5 different drug options for every mutation. And so this team can get together and look over this report and the patient history and try to help identify the best treatment for an individual patient.
Is this widely accessible or widely used tool?
I think they've been in academic medical centers for about the last 10 years. Kentucky started 4 years ago, and one of the things that we did in Kentucky is we made it accessible to every community medical oncologist in Kentucky, because they probably don't have the resources in a smaller community practice to put this on. And so that's why we thought as a designated cancer center that it was really important for us to offer this to the state.
And this is lung that's collapsed down from the cancer, causing post-obstructive pneumonia.
At Baptist East Hardin County in Elizabethtown, oncologist Dr. Donald Gooden utilizes the services of the UK Molecular Tumor Board for his cancer patients. Lung cancer makes up a huge part of his practice.
Historically, the treatment for lung cancer, metastatic lung cancer, was cytotoxic chemotherapy. And those individuals with metastatic cancer that got chemotherapy, the average survival was around 9 to 12 months. And that was even with treatment. And the outcomes with the targeted therapies and with the immunotherapy, some have been quite amazing. I've seen patients treated with immunotherapies and targeted therapies that had their cancers shrink away from one scan to the next, so that there's dramatic improvement in their disease process. Had people that have lived several years on immunotherapies or targeted agents, such that you can almost start to think of metastatic lung cancer as a chronic disease.
Dr. Gooden credits the Molecular Tumor Board with helping him connect his patients with these life-altering treatments.
The biggest barrier we have for our area is transportation. The Molecular Tumor Board is a way for us to get someone from our community to the university without having them go there directly. So it allows us a mechanism for those individuals to be reviewed, especially if they have a mutation. That also allows us to a way to access the medications that are directed against those mutations. So they're typically all FDA-approved medications, so we do have access to them, but having the Molecular Tumor Board as a second opinion, if you will, I think makes it easier for us to obtain those medicines. And I think that's been the major thing that we see with Molecular Tumor Board.
So we just did an analysis of our Molecular Tumor Board and we focused it solely on lung cancer, non-small cell lung cancer. And what we're able to show is that patients who received a review from the Molecular Tumor Board had improved overall survival compared to patients diagnosed in Kentucky with the same stage of disease that did not have the Molecular Tumor Board review. And the other thing that we think is really important about this is we looked did it matter if the patient was treated in the community or in an academic medical center, and it did not. So as long as they've received the Molecular Tumor Board review, they did just as well as the patients in the academic medical centers.
So this has been a missing link for some time before you came aboard from Wisconsin to University of Kentucky.
The reason that we all got into cancer research was to help people. And I'm really gratified. That's why I go to work every day, to just be able to help people, just even in a small way.
Yeah. Because of the UK Molecular Tumor Board, all Kentuckians can have access to state-of-the-art treatment recommendations and clinical trials for lung cancer. Over 2/3 of people with lung cancer are former smokers or never smokers. We were fortunate to bring together 3 survivors who are members of this group for a conversation about how they came to be diagnosed and what they want people to know about lung cancer. Well, welcome, Lindy, Steve, and Kathy. Appreciate you all sharing your stories with us. It's good to have you in our studios. Lindy, I'll begin with you, and it's a question to each of you about sharing your journey with lung cancer with us, and tell us about your diagnosis and treatment and where you are now.
In the summer of 2017, I was having just some acid reflux issues, and my doctor thought she might just go ahead and just x-ray me in August of 2017. And she called me to just say, you know, there's a small shadow on your x-ray, but I had not had any known risk factors for the disease. And so she said, it's probably nothing, but let's get you a CT scan. And so after the CT scan, it did show a 1.2 centimeter nodule. Typically, a lot of people, there's not a lot of concern, but we just pushed to have it watched for a couple of years. Finally, doctors in November of 2017 said, you know, we need to get it out. Nothing should be growing in your lungs. I woke up to my doctor standing by my side, and he said, we took 2 lobes of your right lung out. Your nodule was lung cancer. So I don't think I knew to really worry at the time. I just thought, oh, they got it all, so that's good. I knew nobody at the time living with lung cancer, so nobody was talking about it. Anybody I knew or anybody my friends or family knew had passed from lung cancer. Meanwhile, I got scans every 3 months and was basically just told I was cured. So took about a year and a half, and then some spots started showing in my left lung. It too was cancer. Now it was time to do some biomarker testing on it to see if I had a mutation, there was any reason for this cancer to keep growing in my lungs. And it did come back to show that I have what's called EGFR exon 19 deletion, which is a mutation. It's basically damage to the DNA in your lungs that we think might possibly have come from some previous exposure to radon and secondhand smoke. So I'm now on a targeted therapy pill that I take every day, and I will take it unless or until the cancer starts growing again. So we just have to understand and erase the stigma and realize that one, we don't need to look at the cause, we need to look at the cures and
it's a really good way
really understand that there are multiple causes. You know, the stigma has just stifled progress for so long.
Kathy, you were shaking your head and said yes when you said, you know, look at the cure, not the causes.
Absolutely.
And we want to maybe assign some blame because it's behavioral choices if you were a smoker. So tell us about your experience.
So mine goes back to 2003 when my otherwise very healthy, very independent mother who lived in Michigan, owned her own business at age 75. She was in a car accident. They did some scans and found something that didn't look right on her lung. They ran some more tests, and she had stage 4 lung cancer, just out of the clear blue sky. And she passed away 6 months later. And so in that process, because my mom had none of the risk factors either, so I started looking into it a little bit more, and I found out about this low-dose CT scans. Fast forward, I was in just having my regular annual exam with my doctor, and I said, you know, I've been seeing something about these low-dose CT scans. I said, I think maybe I should get one. He said, you're very healthy, you know. I'd quit smoking like 30 years ago, and he said, I don't really think, he said, they're not even covered by insurance. I was like, well, how much are they? So he had his nurse check, $185. I said, well, let's just do this, you know. So I had the first one. It showed a shadow. We followed up in 6 months. Still a shadow. He said, I think we're good. Nothing's changed. I said, let's just do one more, just one more. And sure enough, it had grown. They did a needle biopsy, and it was malignant. And I don't know who was more shocked, the doctor or me. You know how you know about your body and you just listen?
Right, because you were insistent.
I was insistent, you know, against the doctor's orders.
Right.
That was 7 years ago. I had the left upper lobe removed and didn't have to have any chemo. And as you know, I owned Today's Woman magazine until March when I sold it, but I used that as a forum to get the word out. It's a very insidious disease. It kills more people than breast cancer, cervical cancer, colon cancer combined.
So are you hopeful about your future?
Oh, I'm very hopeful. I had to have annual scans for the first 5 years, and after that, my doctor said, we're good.
Yeah. Steve.
So my story, I'll take you back to 2014, the latter part of that year. Actually, a month after having been married to my wife, Sarah, Sarah told me that my mother had read an article in Today's Woman that she always reads. And in it, actually, she seen something that said that she thought maybe I had met all criteria to get a low-dose CT scan. And it's something initially I discounted, thinking, I'm great, I feel fine, I'm healthy, I don't need a CT scan. So she was persistent, as was my mother, and you know, had the low-dose CT scan done. And just, gosh, it was just the most shocking news I think I've ever received. The nurse came in and said, we're gonna call a doctor in to talk to you. So they, you know, got us all back in the room, and they said, we see a couple spots. So nevertheless, I had a PET scan done, but they said, you definitely have lung cancer. But the worst part was it wasn't in one lung, it was in both lungs.
Oh, goodness.
So immediately you think, okay, how long do I have?
Right.
I did qualify for surgery because it had not metastasized or anything. It was localized within my lungs. So immediately they took me in, and I had the entire top portion of my right lung removed. And 2 months later, after enough time for me to kind of heal, they did the same thing with my left lung. I honestly say I felt like I was blessed.
Right.
I feel like I owe it to Kathy's article in Today's Woman, because
Yeah.
I tell you, it's quite amazing how you find something. The awareness is not there,
Right.
but you find something, and it changed my life.
I was
So,
just getting ready to say, and to have both of you here in this
Yeah.
circle or diamond,
Sure.
right? That Kathy, you could have saved Steve's life,
Absolutely.
or in fact did,
Yeah.
right? Because of
Absolutely.
your advocacy of what you were doing in a media platform with the broad audience that Today's Woman has. So it goes to the what could the media be doing, right? Because lung
Yes.
cancer is not
Absolutely.
something that is talked
Yes.
about as much as other forms of cancer and diseases.
The biggest problem is funding too, though, because there's not enough research for when one treatment fails, you need options. And so many of these treatments, the targeted drug that I'm on has shown success for about 18 to 36 months. So we need options when the cancer begins to outsmart the
Right.
treatments. And that's the biggest failure right now, is the lack of funding for this disease. For a lot of the reasons that we've mentioned, the stigma being the main one.
I just want to ask you, and I'll start with you, Steve, to give
Sure.
one final takeaway. You know, if viewers don't learn anything else from this series and they hear just one thing, what do you hope it would be?
to me, it's all about clean air, and really take advantage of the cleanest air that we can breathe and take in. And
Any final takeaway from you, Kathy?
I would just say, if you have lungs, you can get lung cancer. Sadly, that's the kind of the big takeaway. If you have lungs, you can get lung cancer.
Lindy, last word.
Yes, my hashtag is anyone with lungs, and that is one of the biggest messages we've got to push through, and giving platforms to the survivors, larger and larger platforms, because sometimes I feel like we remain in a bubble helping each other,
Right.
but we really need the media, we need large organizations, we need even celebrities who are diagnosed to really speak up and help us fight this cause, because it's a big one. It's a wildfire.
Well, thank you all for fighting.
Yeah.
Thank you so
Oh,
much.
we won't stop fighting.
thank you.
I have no doubt about that. None whatsoever. As we've just heard, reducing the stigma surrounding lung cancer will further advancements in research and treatment, which will help everyone affected by this disease. Well, that's all for this episode of Fighting to Breathe. Remember that anyone with lungs can get lung disease. Clean air is essential to life and is something we all should be fighting for, both for ourselves and our fellow citizens. Please visit our website at ket.org/respiratory for more information and to watch an archive version of this program. Thank you so much for joining us. Be well, stay safe, and we'll see you soon.